Kia ora, my name's Margie Olds, and this is the Glenohumeral Gurus podcast. This is a podcast for clinicians interested in shoulder rehabilitation. I'm a shoulder therapist based in Auckland, New Zealand, and in this podcast, I interview clinicians and researchers across the globe about their research and their clinical practice on how we can improve outcomes for people with shoulder pathologies. The aim is to learn, laugh, and try to work out how we can help people with shoulder problems. Enjoy the podcast. This episode is brought to you by Flawless Motion, shoulder braces that are designed for people with shoulder instability in male, female, and bilateral versions. So check out flawlessmotion.com for your shoulder brace requirements. We've also just expanded now to the UK, so if you live in the UK or Europe, you can get your shoulder braces much more quickly. So check us out at flawlessmotion.co.uk and you can check out our shoulder braces there. Cheers. This morning is my great pleasure to welcome Wieger Heijink to Glenohumeral Gurus podcast. Wieger, I'm so excited to hear all the things you have to talk to us around motor learning and your approach to rehab. Can we firstly start with your physio career and maybe just introduce yourself to the audience a little? Tell us
Yeah.
about you.
First, thank you very much for having me in the podcast. I'm really honored and delighted to be here. My name is Wieger in Dutch, so we talked offline. We could make a podcast about how you pronounce it, but it's pronounced in Dutch Wieger Heijink. I'm a Dutch physiotherapist. I've been a physiotherapist for a long time now. I was graduated in 1995, so that's long ago, and I'm a manual therapist also. I'm doing dry needling, ultrasound, approximately everything you can find. I've done courses. And then I think it was in 2001, I went for the first time to a shoulder course. It was it was a 3-day course. Um, and they started this course with questions. They had about 30 questions, multiple choice. Everybody had colors, so 4 choices per answer. And when they gave the answers, I had 2 right answers and 28 fails. Oh man, and that triggered something in me. So I was
Wow.
really, yeah, after that, it was a really good course. I really liked it. And they started with Kipler. They mentioned Ancols, who was doing the research by then. So after that, I went to every course I could find, and I went visiting orthopedic surgeons, other physiotherapists who worked in the field. And that really triggered me to go into the shoulder, and going on. And then a few years later, I met Dr. Maarten van der List in Holland, a very famous shoulder orthopedic surgeon.
Mhm.
And he sent even more difficult patients to me because he noticed that I was very eager to work with them and did some things a little bit different. So I got these cases from all around Holland, which were pretty difficult. And the only thing I knew by then was I don't have to do the things everybody has done already. They had
Yeah.
perhaps seen 7 or 8 physiotherapists. And I was thinking, yeah, doing the same thing will give the same result. So I have to change things. And so I went exploring and searching for other options and things. And one thing in the time that was, the wall slides,
Yeah.
the exercise.
Yeah.
So the wall slide to train the lower trapezius to get more activation there. I did this with some patients, and what I always did, I always filmed everything I did. I have a lot of video footage from everything I did. And these wall slide, most of the time, were pretty painful for the
Mm.
patients.
Mm.
So I thought, well, perhaps you should do it on the wall, but do it on the table. Not so much upwards. And that went better for the patient, but still wasn't very comfortable. And then I thought, well, perhaps I should use gravity and just go down. So touch the other foot, touch the left foot when they're standing. And I had some patients who really acted well on this exercise. They were really getting better. And I thought, whoa, that's nice. That's amazing. We've got something here. Didn't know why it worked, but it worked. But you can't do this exercise for half an hour or for 1 hour when they came from far away. So at one point, I started to do some things, standing on a bosu, standing on one leg, doing some variations on it. And then these patients, they really accelerated their recovery.
Mm.
So I started doing that more and more and finding more tricks, but I had no idea what I did. I really had no idea. And then I went to a course from Frans Bos. He's this famous athletic trainer. I think you know him, giving all these courses on motor learning.
Yes.
And it was a 3-day course, and I was sitting there the first day. And about lunchtime, I was thinking, man, this man is telling me what I'm doing. He was really
Ah,
explaining
okay.
to me what I'm
Yeah.
doing. Yeah,
Yeah.
so implicitly, I've learned how to use it, but I had no clue. And then
Yes.
I learned about the complex dynamic system, ecological approach, implicit learning, and everything. Yeah, and then it went on and on. And now I think we have a really great idea about how we can train people with shoulder pain
Yeah.
on a very different way
Yes.
with a lot of success.
Yeah.
Uh,
So
and I'm giving
before we
courses myself
dive,
now.
yeah, before we dive into that, because I'm really interested to learn what you know in that space, do you think this is appropriate for everybody or just the people who haven't responded to traditional approach? Do you know?
Oh,
Because
I think everybody. Yeah.
why do you think that? Because your cohort, similar to mine, is people who have failed physiotherapy doing traditional approach. And
Yeah.
sometimes I catch myself thinking, well, because I have a way of working, like you have a way of working, is this for everybody? And I'm like, well, if you'd done this in the first place, you wouldn't be here. But I imagine that's the same that you
Yeah.
think. But for some
Yeah.
people, you don't see the ones that you don't see. I guess that's my
Yeah.
question to you. For some people have already responded doing it a different way. What do you think about that?
Yeah. Well, first, when we look at the numbers, when you get shoulder pain, after 1 year, the chance that you still have complaints
Mm,
is it's more than half. It's
yeah.
60% of people after 1 year still have problems. So we're really bad at treating
You're talking
shoulders.
about rotator cuff related shoulder pain. General
Just
any
generally,
type of shoulder
generally,
pain.
any type of shoulder pain. It's when you look at the numbers, it's really bad. It's really bad, and
Mm,
it's with or without therapy.
yeah, right. Which is not
Yeah.
such a bit of an indictment for us.
No,
And so,
no. So that's hard, but
yeah,
um, I think it's very easy to tell where something gets struck. Yeah. So when a shoulder doesn't work anymore, we can tell, well, it's the rotator cuff problem. There it's stuck. But it's very hard to tell how does his arm really moves.
yeah,
How do we really learn how to move? I mean, when I
yeah.
ask you, how does somebody move his arm up? Yeah,
Yeah, it's
it's
really
hard to
complex.
explain.
And I think
Yeah,
for me, that's the thing that has attracted me to shoulder problems because of the complexity of the
the
trunk and the
complexity.
scapula and the
Yeah,
multiple different ways and probably and more so into instability because some of these people have multiple different strategies to
yeah,
move in the
to
way
move.
that
Yeah.
they move, don't
And
they?
so I think we have to answer a few questions if we start working with shoulders. And the first one really is, how do we learn to how to move? How do we do
Mm,
that? What
mm,
are the principles of moving? And then you come into modal learning and everything.
yeah,
Then the second one is, why do people get in trouble when they have an injury? Why don't they cure? Why is there no recovery sometimes? And the third one is, how can we use these two together and make
yeah.
an appropriate strategy for them?
So
Yeah,
let's walk through some of that then. So my plan today is that we talk firstly in this first podcast around modal learning, and I've got lots to learn from you in that space. And then we do a part two version that talks
yeah.
more about applying that into rehab.
Into,
So
into rehab, yeah.
if we dig into the modal learning and how people move, what can you tell us about that? What should
But
clinicians know?
I think it's really important to know that learning how to move is a self-organizing system.
Mm-hmm.
And that's very different from everything we do, because when we tell people how to move,
Yes.
we're really using their cognition. We're telling them, hey, keep your shoulder down. You must just use this muscle, use your abdominals, whatever. Now we're telling them how to move, but
Yeah.
learning how to move isn't a cognitive thing. It's a self-organizing thing. So intention of moving is a top-down system.
Yes.
And learning how to move is a bottom-up system. Though there's not a, how they call it, a central executive who's doing it, it's the system organizes itself. And it can
Mm.
organize itself when it has a task,
Yeah.
and it's always in an environment around it. So when you have kids, when my kids were young, they're really young, and they learned how to walk, it wasn't like I'm telling them, put your
Yeah,
foot
take a
before the
step.
other foot. How
Yeah.
did they do it? They were standing and it was like, come, 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 come. And you just make it really attractive to go there and that make it fun. And then they're like walking towards you and you encourage it and they go a little bit more. So they have a really great task to go to you.
Mm-hmm.
The
Mm-hmm.
environment is very fun. Come on, you can do it, you can do it.
Yes.
And then this behavior emerges, and then you learn how to walk.
Yeah,
And
because you then
that's
repeat
what,
the active or you repeat the motions.
yeah, and well, it's not repeating the motions, it's learning how to be skillful in an environment.
Yes, yes, but
Yeah.
that comes with a degree of practice, I guess that's what I was trying to say. That you would practice and then not do it so well that time and then do it differently this time.
Do it
You,
differently the next time and make it harder, and then it's learn running and everything.
yeah, yeah, yeah.
But that's
Yeah,
really implicit learning, and the pediatric physiotherapists do it all the time with
yes,
their kids. And
yes.
then when you become 18, you get an elastic band and
Yeah.
you do very boring exercises.
Yeah, 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 yeah.
It's a
So
little bit funny.
the argument is there is pathology in the supraspinatus tendon. If I rotate externally, I am creating load and through the supraspinatus tendon, therefore that is addressing the pathology. What's
Yeah. So, and then we come to a very important thing. What I'm talking about are complex systems,
yes,
complex dynamic systems. Dynamic means they're changing all the time,
yeah,
and complexity means they're not linear. They have this certain how do you call it? Well, one of them is they're not linear. So when you talk about supraspinatus has a tear, we put load on it, then you're talking about a linear system. Putting load in it will make the supraspinatus tear better, will make the function of the cuff better, will make the movement better, will get the function better.
mm,
But the complex systems, they don't work like that. There is so much influence from everywhere. It's really hard to tell how they connect, how they do, and what influence it is. It's not this causality. And that's what we also see, because not there are very much people who don't respond well on these exercises.
yeah. Yeah, but I guess
Yeah.
that takes us back to that first point in that some people do respond well, but if they
Yeah,
didn't
but
respond,
of course, but the question is, do they respond thanks to the exercises or do they respond
yeah,
despite the exercises?
yeah, 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 and all that
Yeah.
therapeutic alliance and the that
Yeah,
self-efficacy,
and
all that kind
is
of
it
stuff.
really so that they don't cure because the supraspinatus hasn't enough load,
Mm, mm,
or is there something else going on there?
yeah, okay.
Yeah.
So talk to us then about some of the definitions that clinicians should know. So I mean, you mentioned
Yeah,
there.
so we have these lot of assumptions in physiotherapy. One of them is when the supraspinatus has a problem, we have to put load on it.
Mm,
And it's not even an assumption anymore, it's a statement.
yeah,
It's so integrated in everybody. All the world is using the elastic bands. It's a
yes,
statement. It's the truth now. But we
yeah,
have
okay.
to take a step back. It's just an
Mm,
assumption. And when you look back where it's coming from, there are a few ideas. One of them, it's coming from bodybuilding. We've got one muscle from here to here. If you want to make it stronger, you isolate it and you train it.
yes,
It's a really smart idea to get all the muscles really visible, but for function, it's pretty stupid. It
Yes.
doesn't make sense. Another one is, like you said, when it's teared, you have to put load on it and it heals. But the question is it really the tendon that is the problem there? I don't
Mm-hmm.
know. And also
Yeah.
then we have a linear system. A gives B, gives C, gives D. Yeah, what if the system is not linear? Then you have a big problem already.
Yeah, okay. Because
I'm
by
getting
making
you? You're
it too
getting me?
simple, yeah, yeah, no, I hear you. Yeah, and what
Yeah?
you're saying is by making it too simple, we have missed all the complexity that exists, is what you're saying.
Yeah. And a second thing from complex system is that so one of them is they're not linear and they have phases. It's like when you are walking and you'll have to go to your train, but you're a little bit late, so you start walking faster and faster. And when you go faster, there's one point you start running.
Yes.
At that point, your body takes a whole different way of organizing itself. It's a whole different way of organization. Yeah? And there's
Hmm.
nothing in between. There's this phase between walking and running, nothing in between. So that's not linear anymore.
Yeah,
It's not
okay.
A gives B, gives C, gives D. More speed gives you another way of moving just out of the blue. It's the same when throwing a ball. When
Mm-hmm.
I let you throw a ball, you make a really throw movement, and I give you a little bit heavier ball. You're still throwing it. When the ball's getting heavier and heavier, at one point you start pushing
Pushing.
it.
Yeah.
And pushing is a concentric movement. It organizes with concentric muscle power,
Yes.
while throwing is an elastic movement
Mm.
with a lot of rotation in it.
Yeah,
So your
okay.
organization changes from one point to the other.
Yeah.
And when
Okay.
we think about that and we look at injuries, people have no problems, have no problem, have no problem. Bam, they get an injury, they get pain.
Yeah.
And probably before that, there have been already been steps there
Mm.
that, with when we look backwards, could have predicted they get in trouble. There are a
Yeah.
lot of research now in running that like these stress fractures or
Yes.
overuse tendons and so that before we already can see that the gait patterns are changing. They are already changing in the patterns, but nobody notices. And backwards
Mm.
see, hey, whoa, a few months before we already saw the changes. And then
Yeah.
one point they get injured and they don't get away from it. So they're in a
Yeah.
new phase and just treating the tendon is not helping them getting their gait pattern back.
Yeah. 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 I
So it's
understand.
really more difficult than that.
Yes. And I
And
think
then,
we're
and
so limited in what happens in the shoulder and that how we assess the movement, biomechanically. You look to lower limb, you could probably see then the cadence change or those, like you say, but in the shoulder, the movement is way more complex. And so it's
yeah,
way more difficult for us to even analyze with 3D markers, and we don't really know 100% how to even marker up the scapula. So it's
yeah.
very,
And that's a difficult thing, yeah.
yeah,
And when we look at how people learn to move, one of the founders of that was a Russian professor, Bernstein. I
yeah,
don't know if you ever heard of him.
yes, yeah,
With and he described a few beautiful things. One of them is the degrees of freedom problem.
yes,
And he said when he did the first research on blacksmith, and what he
okay,
discovered, when you have a blacksmith, a very expert blacksmith, he hits the nail every time with the same speed, same direction, really right on top. But his movements were different all the time. He never had the same movement.
yeah,
And
okay,
novice blacksmith, they had a very repetitive movement, but
mm,
didn't hit the nail very good.
yeah,
So, and this is the opposite of what we're doing in therapy. In therapy, we're like, oh, you have to move like this. We have to have
yes,
this scapula moving like that,
yes,
repeating the movement. But the end point should be stable and not the movement itself. The movement itself should be
yes, but you
variable.
could argue that our patients are then novice learners, so they will, in the
Yeah,
same way that your novice blacksmith will do repetitive tasks and do
yeah.
it
And
slightly
so
differently.
And that's the problem. Our patients are already on the level of expert movers, but through pain, so they're very
Yes.
variable, they have movement, they have control everywhere. But through pain, they are freezing degrees of freedom. They get stiffness,
Yes.
they don't, yeah, their how do you call it? Their range of motion is going down. They're not really capable of these sudden movements. They get pain.
Yes.
So so they are limiting all their options, like novice learners do, to make it
Yes.
more comprehensible. But they shouldn't because they're experts.
But
And when
then,
we look
so
at that
then
in
I
that way,
wonder, so I have
then
then approached people as becoming novice learners again in terms of how they recruit different strategies. They no longer because and we're sort of jumping ahead of what I want to talk to you about, but they no longer then recruit muscles in the same way. And so if you would like them to do that differently or learn available options, you have to treat them as a novice first and then layer them up. That's how I would have dealt with that. Would you agree or disagree with that?
yeah, I do the treatment a little bit different, but
Yes.
the thought is the same. The thought is the same. So when they're novice learners and they're moving all rigidly and don't know the
Yes.
options, I will put them in situations where they will have to go explore their movements. And
Yeah,
what
okay.
I discovered is that balance is perfect for it because when you're really rigid
Yes.
and stiff, you're terrible at keeping your balance.
Yeah.
When I put you into a situation where you have to stand on a bosu and turn around, you have to explore how to do it. And this
Yes.
exploration starts from proximal to distal. So you start moving in your spine first, then you start
Yes.
moving your scapulas, and
Yes.
then you start moving your arms. And the
The
fun part of
argument
it,
to that is around the focus, though, isn't it? So that you don't
always,
have your focus is now it's not really about how your arm moves. Your focus is
never.
standing on
It's
the
focus
ball.
is standing on it. It's every time and so we use an external focus.
Yes.
And the problem which I have with exercise with a band, there's no feedback in it. You don't
Yeah.
know when you do it right. There's no
Yeah.
feedback system. And if you want to learn, you have to have feedback. There has to be some
Way
feedback
of
in,
closing
are
the
you
loop.
doing right or not? And
Yeah.
when you lose your balance, you know, hey, I didn't do well. I have to try again. So there's
So
always feedback.
fascinating. It's so
Yeah,
fascinating, isn't it? I think
yeah.
for the younger clinicians learning, can we just step things back a little bit for them? Can you define then the implicit versus explicit learning? What can you tell
Yeah.
us around that for younger clinicians? How would you
Yeah,
explain?
not only for the younger, also for the
Yeah,
elder.
okay. I was trying to be generous. So for all the
No,
clinicians listening, can we
yeah,
just
so
recap some definitions?
yeah, so we talk about self-organization here.
Yes.
And self-organization means the body is exploring itself. And when we go tell people what to do every step, that's called explicit. We're explicitly telling them how to
Mm-hmm.
move. But
Mm-hmm.
I want them to explore themselves and do it implicitly. So
Okay.
I think implicit learning is you give them a puzzle and they have to solve the puzzle themselves.
Mm.
Explicit learning, you give them the pieces of the puzzle and tell them where to put them.
Yeah.
But I don't want them to have the pieces to give them the pieces. I want them to learn how to puzzle.
But you
And
also
when I've done the
need,
puzzle,
yes, yes,
yeah,
you need them to be successful, eh? Like you
yeah,
have to, and so how do you give them a puzzle that they can solve? Like how do you not make the puzzle too hard? I guess is my
yeah,
question.
that's when they fail all the time, we make the puzzle a little bit easier. And
Yes.
there's yeah, like with children, you give them a puzzle of four pieces when they're really small, and then you make them
Yes.
with six, with eight. So
Yes.
when I have this older patient, I just let him standing on a bozo, and it's very, very hard already. Yeah, I'll make it easier. I let them walk in a line, foot by foot, on one
Yes.
line, and that might be already hard enough for them.
Yes.
Yeah.
But you would always first put them on the BOSU. How do you measure the
I
level of the? puzzle, I
We
guess,
have
is
you
what I
have
want to
all
know.
kinds of things, but it's always has to do with balance. I've also have Olympic contestants.
Yes,
We put them on a slack line with water bags and
yes.
all kind of this disturbance. I can't really train with them because their level is so high. But we give them really, really difficult puzzles, and they know how to solve it. But
Yeah,
in
okay.
that puzzle, there's always movement. You always have to explore, so you get rid of your stiffness. There's
Yes,
always these unexpected things in it. And
yes,
every every moment of your movement, you will have to control it. When your arm
yes.
is already behind your back, you have to use it again. Otherwise, you will fail in
Yeah.
your balance.
And what about when it's painful for people? What does that mean for you? Like,
That-
say I'm a dislocator and I put my arm back here in abduction, external rotation, and I, like, as a therapist, would be like holding my breath. You limit what they can do from a safety point of view. What is your
yeah, of
thoughts
course,
there?
of
You're
course.
bothered by the pain that, say, a cuff
Yeah,
hurt.
yeah, yeah. I want to train pain free because the pain is the thing
Okay.
that gives them the how do you call it? The decrease in movement patterns.
Yeah, okay.
So
And that
pain
they're
is
trying to
disturbing
avoid the
everything.
pain.
Yeah.
Yeah.
So
Yeah.
what we're doing, and now we're already getting a little bit into rehab,
Yeah,
we're
which
just
is part two. So we need
yeah,
to.
but it's part two. But it's a good question. So when you have pain in the shoulder, I let them have their hand in the pocket of the
Yes.
trousers. I'll give them a sling, and then we're going to do the same exercises. So they can't use
Okay.
the shoulder, but they're
Yes.
moving everything else.
Yeah,
So I'm
okay.
doing exactly the opposite of the elastic band exercise. The elastic band is your body isn't moving at all.
Yes.
We isolate your shoulder,
Yes.
and nothing is moved except your shoulder. And I do it all the way around. We protect your shoulder and we
Yes.
move
Move your
everything around.
body. Yeah,
It's
okay.
it's like when you have a volleyball team.
Yes.
You're the six. There's no other people you can use, and one of them gets injured. What are you gonna do? Are you gonna put the other five around, train the
Mm,
one till he's better, and then the other
mm,
five can come in again in
mm.
the field? How do you get the injured out? The other five have to use other patterns. They can still play. They don't have to lose with five against six.
Yes.
And when the one is getting better, you can get him into the field, play a few points. When he's getting tired or having pain, you put him out again. The other
So
five
the
can play all over.
argument to this, Vika, is that actually the by moving the body and limiting the shoulder, though, we're not actually focusing on where the problem is. Or you would argue that the problem is in the balance. Do you know, like,
The problem is that the movement patterns have changed, that the scapula isn't moving,
yes,
that the muscle synergies aren't moving. That's the problem. And I'm training that. I'm training the scapula, I'm training the muscle synergies, I'm exploring all these different things. I'm just protecting the structures that are need to be healed.
yeah, okay,
So, but
okay,
thinking that the shoulder itself is the problem, no, the shoulder is the victim.
okay.
The shoulder is the victim of the things going wrong. So
And
when
so
you
you
protect
are
the shoulder
addressing
and you
those
train the rest,
underlying causes, is it would
yeah,
be your argument.
yeah.
For
So
the
and
one other definition I wanted people to understand then is around internal and external focus. What can you tell us about that? Does this feel like an
yeah.
exam? It's suddenly you were
Well, I know this answer. I know this answer. So I'm
so
not
that's
getting into.
okay.
I only have two answers good and the other 28
It's a
false.
very interesting discussion. Tell us
No, no,
the
no.
answer you know.
Internal focus is about, do you put your focus on your body itself? That's
Yeah.
internal. You think about your shoulder, your elbow, how you have to move, your body parts and everything, and how your muscle tension is. While external focus is the effect of your movement, the result of your movement.
Mm,
When I'm throwing a ball, I want to know if I hit the target. That's an external focus.
yeah.
And I don't want to think about my shoulder blade. I don't want to think about my elbow. And
No.
there's the really great part is there's so much research on it.
Mm,
How do you say it? The evidence is massive. External
yeah.
focus is much better than internal focus.
Yeah.
Really,
But
every
for
sport,
novice learners, I guess, and that's maybe
everybody.
fundamentally, you need the internal focus to
No,
start with.
no, you don't.
You would say go straight for external focus.
Yeah,
Don't worry.
the research now says if you wanna research on another sport, if external or internal focus is better, they
Hmm.
say you don't
Hmm.
have to do it. You can
Go
stop.
straight for external focus.
We know that external focus is better in every sport. And still, so there's a lot of evidence. External focus is better. We use it in kids, we use it in animals, we use it
Yes.
everybody. But with physiotherapists, we have the statement, but we still have to start with internal. It's
Wow, that was my understanding of that modal learning progression and how you would like if you wanted to change movement patterns, then you would start in it with an internal focus and progress them. You would say
yeah,
that
but
you could just go external right from the beginning.
but when let me ask you the question, when do you change from internal to external? When do you know you have to change?
Once you have control through range, I would have said.
And when you don't get there, you never go to external.
Yeah, so then I would use that as a different strategy. I hear you.
Yeah,
The thing
so
is
why would we
picking
start with
what,
something
yeah.
that the whole research says use external focus, but in novice we also in novices it's the research hasn't been done only on expert learners.
Mm,
There's this great and this is more about it also has to do with focus. There's this great research on implicit, explicit learners between shot put.
yes,
Uh, two groups, never had done it before. The first one get the national Austrian trainer. He's really good, really,
yes.
really good. All the high athletes, high elite athletes training with him. And the other one, they just get a centimeter. They just run a throw and they measure it. Yeah.
Okay, yeah.
So the first one is just focusing, let's throw a little bit further. And the other one with the coach is really on the explicit learning, telling them
Yes,
how to do it, how to stand,
yes,
how to throw.
yes.
So they train for 6 weeks. Everybody gets the same amount of shots they're doing. After 6 weeks, they do this match. They do a match. And the fun part is the group with the coach wins. They're a little bit better than the other group. Not much,
Yes.
but they win. Then 12 weeks later, they do another test. They haven't
Wow.
trained meanwhile. And then the group with the
Okay.
centimeter, who hasn't
Yes,
trained at all, they throw the same distance. Their
yes.
body has learned how to do it. And the group with the trainer, they fail every part. They throw miserably
But that's
because
about
they have to
learning
rethink
versus
about it.
performance, isn't that's what you're talking like you're is that not true? Is that the learning process versus actual performing? And so maybe then the
And
ex
there's no
so I
retention
still
there.
sorry?
Yeah, there's no retention. So
Yeah,
when you're really under pressure and you have to go thinking about how my body is moving,
yeah,
you're really disturbing the self-organization of your body.
yeah.
Your body is really capable of doing it itself. It's really capable of learning how to move, how to do it yourself. We don't have to disrupt that.
But what if,
And that's a
as
big
a
difference.
clinician, I could short circuit that for you? What if I could say, oh, why don't you try it this way? Why didn't you try it that way? And you give people some options rather than you just let them, wouldn't that be faster? Like I'm trying to get
Yes.
my people back
But
to work, back to their sport, back to their jobs.
but now comes the fun part. When I see that their option they're using isn't a very smart one or very efficient one, I'm not telling them the options. I'm manipulating it by using
Okay.
constraints.
Yeah, okay.
So I put them in different positions where they
Yes.
have no other options than moving the scapula or getting
Yeah.
faster.
Yes,
So,
I
and then it's really
understand because I
fun.
do
Then
a
we,
similar thing. I do a
yeah,
similar thing for the for
you
similar
do.
reasons. Maybe
Yeah.
not as structured as what you're doing. Yeah, I would say
But,
because my
but
approach has been thinking around cortical plasticity and
when,
how
when my, when my colleagues and my secretary hear that you call me structured, they will laugh very
Yeah.
hard.
No, but the underlying theory is very structured in that space, eh?
Yeah, yeah, it is. It is. I
And
hope.
similarly, because I think then about cortical plasticity and changes in terms of the way, the space that your motor homunculus man, that's what I call him, in your
Yeah,
brain,
yeah.
because we know that changes if you then change your movement so that you don't have that same space. I've got a broken wrist at the minute, and the atrophy that I have and my motor homunculus man for my finger flexors must be terrible
Yeah.
because I haven't been able to flex my fingers. So then I lose that space in my brain. And so I would try to open up the space in the brain to try to make space again for those muscles. Tell
Yeah, but
me,
then, yeah, so in the complex systems, changes when there's pain or fatigue, the changes take place on every level of of your system. So it
yes,
takes place in the fingers itself, it takes place on the peripheral nerves, also in your brain. But when you're now thinking, no, I have to change my brain again to do that, it's a linear system again.
yeah, but I guess and I'm not sure it's that linear because I would start. So, say for an instability patient, we know that then your subscapularis is affected. I would then give you some internal focus, try to cue you, try to then load that up, thinking that I am trying to make space in your brain. Obviously, other things are happening, but I'm trying to help my athletes find a way, like you
Yeah.
are, but just in a
Yeah.
slightly different way.
Yeah, and I really stopped with thinking about the subscapularis or a thing. What Bernstein really nicely put is that moving successfully is moving around different joints. And
Yes,
moving out different joints, we don't look at one muscle solely, we look at muscle synergies. And muscle synergies also work around different joints. So they work around the shoulder, the scapula. That's also the reason why we have uh, muscles around two joints.
yes,
By articular muscles,
yes,
sorry for my English. That's the reason why they are there. You can control two muscles at one time with one muscle. It's really great.
yes,
So when you look at muscle synergies, these are much more important than
yes.
just one subscapularis.
Yes,
And
I would agree. I would agree. But I would
yeah,
try to layer that up for you. I think my approach has been much more around layering that versus assuming that it's going to work.
yeah, but when you're layering it, the assumption is already there. You really need your subscapularis before you can do the other things.
Yeah.
And that is a linear way of thinking.
Yes.
And I think it doesn't do right to the complex system we're dealing with.
Yeah, okay.
So probably your scapularis is get in trouble because the mobility of your scapula isn't there, or your spine is not moving well, everything like there. The control between all the muscles isn't there. And then I want to do exercises where where they have all the muscles getting into control, where we stretch everything. And
Mm.
I don't care if the subscapularis is tensed or not. He has
What
to go with the whole system.
What kind of research do we have for this approach in injured people? Like, I hear what you're saying about applying that for novice versus
There's
experienced.
really, really
Yeah.
not much. We have one pilot study with Annelies Maanhout
Ah,
from
yes.
Ghent.
Yes.
Yeah, we have one pilot study we published a few years ago.
Mm-hmm.
Uh, Last year there was an article about muscle synergies in swimmers, and the start was very good. They looked at muscle synergies between swimmers without pain and swimmers with what they call a swimmer shoulder.
Yes.
And they looked at different synergies and what happened. And what they noticed that two of the synergies in the injured group, the quality of the synergies went down. Like the deltoid muscle in synergy 2 was doing less than the other muscles.
Yes.
And
Yes.
then they came with and I was really shocked there with the theory. Now we have to train the deltoid to get it
Yes.
better. We're looking at a complex system, we
Yes.
look at synergies, and then we go back. Oh, now we have to train that one muscle again. You really didn't get it, I think. You really should get back
Okay.
to the
And what
books
about in
about complex
other
systems.
pathologies? Perhaps not shoulder. What about other joints? What do we know about injured populations and that approach in
It's
other
a lot done
pathologies?
in people with strokes. So
Okay.
people with strokes, they train a lot like this with a lot of
Yes.
success.
Yes.
Knee injuries, they start with it now. I think
Yes.
they could step up when you really use everything about it. It would be better, but still they're using it now. And it
Yes.
makes sense, eh? With knee injuries, you go doing the jumps, you go doing all the things, you work with the
Yeah.
acrobats. Yeah.
Yeah. Yeah.
And
That
they
that
do a
makes
lot of this in baseball. There's a lot of research in baseball, also on what fatigue does with it and everything.
yes.
Yeah, and
Yes.
these results are great.
Yeah.
Yeah, I work
So
together with
interesting.
two Dutch guys, Martijn
Mm-hmm.
Nijhoff and Bart Hanegraaf. Bart is one of the hitting coaches of the Pittsburgh Pirates, Major League
Okay.
franchise.
Yeah.
And Martijn is head of the Dutch baseball and also connected to the Pittsburgh Pirates. They only do implicit learning, external focus, using all these constraints, using all these really great
Yeah.
exercises. They just make them up.
Yeah.
They see something happening. Hey, we want to address this. How can we make an exercise for it? And always with self-organization, knowledge of results.
Mm,
Yeah,
mm.
it's really great what they do. So I learn a lot of them.
Yes. We haven't
Yeah.
talked actually about you and I have we haven't talked about knowledge of results, which is what you're just for
Yeah.
clinicians to understand, because I think we've kind of skipped
Yeah,
that part. But it's
that's
incredibly
the difference
powerful, isn't it?
between
Yeah.
yeah. That's the difference between knowledge of result and knowledge
Yeah.
of performance.
Yeah.
Knowledge of result means I will throw a ball and I want to know if I hit the target.
Mm.
And knowledge of performance is I want to know how you do it,
Yeah.
how your arm is moving. And when we look at people, we look at performance. Hey, we look at how they move and everything. But when I train them, I always use knowledge of result. I give them a puzzle, I give them an exercise.
Mm.
They have to hit the target.
Yeah.
And I'm never telling them how to move, never. I
Mm.
always do the external focus, implicit learning, and use all these principles because I think it works better when we really use it consequently.
Yeah, so interesting, eh? So interesting. So I want to, we need to wrap up this. I knew we were going to talk for hours, which is
Yeah,
why I think
we
we are
are.
better in two parts. I knew this was going to happen. I have a theory, which is at the minute just a theory around the arthrogenic muscle inhibition, and what we know some of that stuff in the knee, and I think when you have, say, an instability episode, you end up with hemarthrosis in the shoulder joint, that then your cuff would shut down. What do you think of my theory? You think that happens or not, and how would you approach that?
And what do you mean with the cuff shuts down?
Because because then of the swelling inside the joint, then your rotator cuff then reflexly is less active, is what I
Yeah, so in when there's an active thing
so
going
with
on
active
there.
swelling in the joint.
Yeah. Yeah, I think you're totally right, and I think that's an adaptive way of moving.
Yeah,
So
okay.
we when you get injured, you will go move differently.
Yes.
Everybody does it.
On
We
that we
do.
can agree.
Yeah, we agree. We agree. And that's very adaptive. That's adaptive. That's really
Yeah,
smart. Your body
yeah.
needs protection. And it can be with more tonus, less tonus. It can be with shutting everything down. People can't move a bit. That's really a smarter way of your body. I've had pretty much injuries in my life, and every time, yeah, well, I didn't move better after the accident than before. It was always
Yeah,
a trouble. But that's adaptive. But when
yeah.
in time your injury is getting better, when you still have these movement patterns, then it becomes maladaptive. And that's,
Okay.
I think, the way of chronicity. And then we
Mm,
should do things.
yeah.
And then we start, but we don't have to start training the cuff. Then we have to look at, hey, are they moving rigidly? They're not moving fluidly around all these joints. That's
Mm,
the thing we have to train then.
yeah. Yeah. Hey, that's been super interesting, Vika. Is there anything else you wanted to include in this first part? Is there anything you think is really important that clinicians understand around motor learning
Um,
and synergies and
Yeah, I
rehab and
think when I
stuff?
summarize it, that learning how to move is a self-organization. It has not somebody in your brain telling how to do it. It
Yeah.
organizes itself, and it is phased. It uses phases. It's a non-linear system. So there's a
Mm.
lot of things going on. We really don't know what, but it's we can leave it to the body, but we can manipulate it. We can use constraints. We can put people into positions where they have to change their motor pattern.
Yes.
And the best way, I think, is using implicit strategies. So not telling them how to do it, use an
Mm,
external focus, knowledge of
mm,
results. I
mm.
think then you get the best results,
Yeah.
even with
Yeah.
novices.
Even with novices. Hey, thanks very much. And people should tune back now for part two, then I think, eh? We
Yeah,
talk
thank you very
more then
much.
about rehab and how to implement these principles in rehab.
Yeah, thank you, Maggie. I really
Yeah,
liked
yeah.
it.
And thanks again to Flawless Motion for supporting this episode. So, if you want to know more about the shoulder braces or other clinician resources, then head to flawlessmotion.com or flawlessmotion.co.uk for more information. Thanks for listening. I hope you enjoyed the podcast and found some clinically useful tips for your patients in clinic. Please subscribe to the podcast and follow me on social media to keep across the latest releases of the podcast. Don't forget, if you need a shoulder brace for your patients, then check out our shoulder braces at flawlessmotion.com. And if you want to know more about assessment and treatment of rehabilitation of your patients, then check out the online shoulder courses at margieolds.com. Otherwise, take care, enjoy, and see you next time. Please remember that this podcast is for educational purposes for clinicians only and does not constitute medical advice. Please consult with a qualified health professional or contact me to book an appointment for individual assessment and treatment. Cheers.